a lot of close collaboration between pathologist and surgeon to understand what margin status really means. Where's it gone? Has it disappeared? Can you see it still?
No, it's gone. We can't see your whole screen.
Where did it just go?
We can just see your desktop now.
Oh, sorry, what happened there? Did it just suddenly disappear? It was under presentation. No, under scope. No, it's not that. What happened there?
So we can see a screen, but the PowerPoint.
Oh yeah, okay, try this. I think it must have just come off for some reason. Oh dear, Haytham. Why has it just suddenly gone off? It's going well, huh? Ah, okay, back. You're back now, yeah?
Yeah.
Okay, Haytham. So we've done this one, yeah. Talked about this. Any questions? So let's talk about sinonasal tumours, okay? I mean, you've got to remember, these are relatively rare tumours. There's only 2% of all head and neck cancers are paranasal sinus tumours. And, you know, the commonest site is the maxillary sinus, which is about 2/3 of them, followed by the nasal cavity and the ethmoids. Squamous cell carcinoma is the commonest type. What you find is that in the ethmoids, it tends to be more adenocarcinomas and minor salivary gland tumours as the commonest histology. Now, have you heard of Ongren's line?
Yeah, it's the line between the angle of the mandible and the midi-canthus, as it is on this photo.
Yes. Why is this important?
In any tumor which is above this line, it will be worse prognosis than anything below.
Why?
I think because of the vital structures being involved, which is the eye globe and the brain.
Yes. Now, remember, you might have forgotten my slide 2 ago. The eye is not prognostic. Remember, orbital involvement is not significant for outcome.
Intracranial, okay.
Only intracranial involvement. So basically, it's closer to intracranial structures, which is why it's worse. So it's important to remember this. Orbital involvement does not worsen prognosis because, in general terms, with orbital involvement, you can accentuate the orbit. Now, if you've got intracranial involvement, and that's, for example, orbital apex going into middle fossa, this is different. But orbital involvement per se is not actually affecting prognosis. So here in Ongren's line, actually, if you've got tumours going into the orbit, it's not the problem. The problem is when they then creep up intracranially into the middle fossa here, or intracranial fossa this way. And obviously low tumours are even easier to resect because you don't even have to think of the structures, the high structures. Yeah, makes sense?
Yeah.
This paper as well, this was part of a SEER database. These are quite interesting. These are big US databases looking at all tumours with all paranasal sinus tumours. So one question is, how many maxillary sinus tumours actually involve the skull base? Well, maybe only 10%. Yeah, the majority actually probably don't involve the skull base. So, you know, this big SEER database said 10% of tumours with T4. So that's orbit, skin, infratemporal fossa, skull base. So actually, the overall proportion of maxillary sinus or tumours that involve the skull base is not that high. We know that smoking is a risk factor, occupational exposure. You know about this classic paper, Haytham, Eggson's paper. He was a British surgeon, published in the British Medical Journal, nasal cancer in the woodworkers of the furniture industry. Yeah. So That's to say that hardwood dust is a risk factor, and softwood dust, any wood dust is risk factor for paranasal sinus cancer. You sometimes see people who are woodworkers who actually have developed paranasal sinus cancers. This paper, the Aikson paper, this one, 1968, is a classic paper in medical journal. It's like the paper that linked smoking with lung cancer. You know, big seminal paper, this link.
Yeah.
Okay, then, so I mentioned that's paranasal sinus cancers. Now we talk about cutaneous malignancies. So, you know, we often see periocular tumors, so large periocular tumors, or skin tumors arising from the nasal skin or scalp. And if these are advanced stage tumors, these can also extend into the skull base as well. So how do these patients present? So what you find is when tumors grow in the sinuses, many times they're asymptomatic. So interestingly, you know, you do often see patients that present with high stage tumors because their symptoms have been put down to chronic rhinosinusitis, right? That's the commonest cause of nasal obstruction and discharge. So some of these signs in particular, if it's blood-stained discharge or unilateral symptoms, can be more relevant. Facial pain or paresthesia of the cheek, which is demonstrating V2 involvement. Displacement of the globe, proptosis. Epiphora, or more advanced stages, other changes involving the skull base. Sometimes you might find facial asymmetry, a bulge in the area of the maxilla, the reduced sensation in V2, reduced eye movements, particularly the medial rectus or proptosis of the globe. You might see bulge in the gingival sulcus superiorly, or other evidence of palate erosion. Imaging is important. We get CT and MR in this setting. CT looking for bone and MR looking at soft tissue involvement, particularly orbit, dura, and brain. So you need both. Yeah. So if you see a patient in clinic you suspect with a sinonasal tumor, I would arrange a CT and MR. So specifically on the CT, you're looking at these areas of bone, the cribriform plate. Yeah, this is all going to help decision making as to what to do. The sphenoid, the clivus, the lamina, palate, pterygoid plate. So this is really useful on the CT scan. And MR, you look at the orbital contents themselves, the extraocular muscles, dura, brain, and soft tissue of the infratemporal fossa. If you've got frank brain invasion, you normally get some associated brain edema as well, which you'll see on the MR. MR is also very useful because, you know, if one of the, say, for example, you've obstructed the sphenoid ostium, you might actually get fluid in the sphenoid. And on a CT, you can't differentiate between fluid and tumor. Whereas with an MR, on the T2 weighted MR, you can actually differentiate between fluid in a sinus and tumor. So it's very useful.
Mr. Mani, would you do it with a contrast or without? So the MRI
yes, with yeah.
Okay.
With contrast.
Sure.
Biopsy, I mean, you can sometimes take small biopsies in clinic. Ideally, if you've got the availability and time, then an endoscopic biopsy is preferable because you can sometimes assess the extent of tumor. Sometimes you can do mapping biopsies, looking at the extent of tumor, for example, you know, if there's septal involvement. And obviously, if there's bleeding, you can control it better under GA. So, you know, I think there's no hard and fast rule. And if it's easy and amenable to doing a quick LA biopsy in the clinic, then obviously this will speed up the diagnostic pathway. But if an endoscopic biopsy is achievable quickly under GA, that's also better.
If you are suspecting an olfactory neuroblastoma, can we still take a biopsy in clinic?
Sure, yeah. I mean, the only caveat with many of these things is bleeding, you know, so I think you just have to be aware that if you get bleeding, you may need to pack the nose. But that, you know, sometimes we do that anyway, don't we? So if you get some bleeding after taking a biopsy, I would just pat the nose with some whatever standard Maricel Rapid Rhino. It'll usually be enough.
Yeah.
Okay, so this is the workup, right? How do we treat these tumors now? So usually multimodal treatment, combination of surgery, radiotherapy, chemotherapy. In general terms, primary surgery is the mainstay of initial treatment. So if tumors are resectable, then you would aim for primary surgery, followed by adjuvant radiotherapy or chemoradiotherapy. You use imaging to help decide which tumors are resectable and to guide approach, and also to plan reconstruction. If tumors are not resectable, then you may opt for an alternative approach, such as induction chemotherapy or radiotherapy. Many times, if a tumor is not resectable up front, it's often more towards a palliative situation. So this was the original paper, another landmark paper, 1963 by Ketchum. This was the first paper that described a combined craniofacial approach. So prior to this, these tumors were all resected via transfacial approaches. And obviously you would then leave tumor at the skull base because you're not able to achieve skull base removal. So he described this combined approach with transfacial approach here and bicoronal approach from above, and then approaching it from below and above. So this is similar to what we do today for many patients as well. So not a lot has changed. Obviously, there's the advent of endoscopic resection, but actually for many of the advanced cases, particularly if there's skin, palate, maxilla, orbital involvement, these are not suitable for endoscopic resection anyway. So there's still, many cases that will still require open resection. So, this originally, for all cases, you do a bifrontal craniotomy, full craniotomy in order to access the intracranial component. But we use more a subcranial approach, which again, I think you've seen, haven't you, Haytham, where you can do a smaller transfrontal craniotomy through the frontal sinus, which still allows good access to the anterior skull base all the way up to the planum sphenoidale, but with minimizing brain retraction. So, less brain retraction, less chance of CSF leak, or if it is, CSF leak can be repaired. As I say, endoscopic techniques are used, but, you have to pick the cases.
But what is the limitation of the subcranial approach, Mr. Mani? Is it like if you're going to the cerebrum, or as long as you're
exactly. So I think, if there's significant dural involvement, or if there's, in some cases, if there's going through the dura intracranially, then your approach is limited intracranially. That's the main restriction, actually. Even you can access, because your access from below is still really good, even posteriorly with the subcranial approach. So actually, subcranial approach is suitable for most cases, apart from those with significant intracranial involvement. So I've said endoscopic approaches can be used for smaller tumors, but once you've got involvement of the anterior maxilla, the nasal bones, the orbital contents, the frontal sinus bone, palate, or posterior involvement, then really you'll need an open approach. And this represents many of the cases we see. So what are you aiming for in an anterior craniofacial resection? This is what in a standard craniofacial resection, this is what you aim to resect. Yeah, so you can see superiorly, just below dura, taking the cribiform plate, the lamina on that side. So this gives a good example. And posteriorly, you can see you take your line of resection up into the sphenoid. This makes sense, doesn't it, seeing it like this? So this is what you're aiming to achieve. As I said, you've got cranial approaches, just like I said, which either bicoronal incision, supraorbital incision, and your transfacial approach can be either a Weber-Ferguson, lateral rhinotomy, or mid-face degloving. So this is a typical example of a standard combined approach using a bicoronal and lateral rhinotomy incision. It's very important to raise a pericranial flap here because this vascularized flap is going to be what prevents any CSF leak. Inevitably, once you've resected the anterior bony skull base, the cribriform plate, because of the way the olfactory fibers insert into the dura, you will inevitably end up with some small dural tears. This is unavoidable. And you can repair these with fascia lata and tissial in the standard way. However, adding this as an extra barrier, as a vascularized pericranium flap, will really reduce your amount of CSF leaks you get. So it makes a big difference, actually, putting this in. So these are, what's the blood supply to this?
Is it the supraorbital, supratrochlear, or?
Yeah, supraorbital, supratrochlear, exactly. You only need one side, but yeah, that's enough. Good.
I remember one of the cases with you, Mr. Mani, when we have planning for an orbit exentration on one side. So we have to keep in mind that whenever we are sparing the artery, it should be on the contralateral orbital
Correct.
side.
I mean, the pericranial flap can survive on a single supratrochlear artery, you know, even on one side. So if you even if you've got a supraorbital supratrochlear on one side, that's enough to well vascularized. You can see here craniotomy, and you can see with this is with the bifrontal craniotomy. What you've got here is you're retracting the frontal lobe, and you then come onto this structure here, the anterior skull base, which has the crista galli and the cribriform plate, and you can make your cuts from above to then join to your dissection below. This is your in a standard lateral rhinotomy. What your approach is from this side. You need to think about the nasolacrimal duct. In many cases, it ends up that with doing medial maxillary, you transect that. This is what I was showing you, combining the two, and you should be able to take the whole thing out en bloc.
Can I ask about the nasolacrimal duct? Whenever I haven't seen a case with you before without an orbital exentration, because at that point the tumor will be into the orbital cavity and the eye will be gone anyway. So why would you go for this approach if it is?
Yeah, exactly. I agree. You know, so sometimes, say in a case like this, the typical example in this case is the tumor is coming anteriorly through the nasal bones, but not into the orbit.
Yeah.
Yeah. So this would be an example when you would use this type of approach. Yep, flap, as I told you about. This is how you reconstruct the flap. Now, we need to think about, you can see the sky hills very well here. We need to think a little bit about reconstruction as well. So, you know, in general, if you're removing the orbital exentration or palate, then you usually would opt for a free flap reconstruction. If it's just soft tissue defect, if the palate's intact and it's only the orbital contents, then usually a big soft tissue flap like an ALT is fine. If you're also removing palate, then you might want to possibly consider, if you're taking the whole maxilla, bone reconstruction like a fibular free flap. So this is what we were talking about the choice of approach. This is what you were asking about, Haytham. So, you know, if the tumor is involving skin, orbital soft tissue, anterior maxilla, nasal bones, then you do an open approach. You know, so for example, like I said, if it's just nasal bones, frontal bones, but not orbit, then you can still use an open approach, but preserve the eye. If you're going to go endoscopic, then you know you should have a small intracranial component, so not really lateral to the medial orbital wall, and you need tissue for skull-base reconstruction because remember you're usually not using pericranium then, so you'll need to use a Haddad flap, you know, nasoseptal flap, to close your CSF leak. I mean, there are also additional approaches depending on how large the tumor is. You know, if the tumor's got extension into temporal fossa, you might need to use other sort of lateral approaches. And ultimately, it's down to the individual, the institutional preferences, skill set, etc. So, you know, like I said, the aim is complete tumor resector with negative margins. Ideally, if you can aim for an en bloc resection, is preferable. Like I said, many times you resect the main tumor bulk en bloc, but then need to do further resection at the margins. Even if you can achieve a macroscopic tumor resection with microscopic tumor still present at the margins, these patients can still have radiotherapy, chemoradiotherapy, and although it's worse outcomes than an R0 resection, there are many patients who are successfully treated. So it's still better to resect a tumor with an R1 resection than not do it at all, because if you're not resecting, the outcomes are basically palliative at that point. So in terms of the actual surgical decision making, you need to think about these specific areas: the cribriform plate and extension through that, orbital invasion and whether you need to do an orbital exenteration, how much maxilla you need to remove, whether it's just medial, total, or palate, sphenoid sinus and how close you are to the ICA, cavernous sinus involvement, infratemporal fossa involvement, and skin involvement. And this will basically, if you can identify each of these areas, this will determine what operation you do, what approach you use, and what you need to resect. So these are really the key things that when I think about a case, or when you think about a case and you've got the scans in front of you, you need to be thinking about exactly this thing you see in front of you here. Okay, so let's go through each one of these then. I'll just go through each one just to give a little overview of what we think about. So, okay, if tumours are going through the bony skull base, then obviously that needs removal. When the tumour has gone into dura, do you need to think a little bit about what is resectable? If you can get dural margins, then you can resect the dura. If the tumor is through the dura into the actual brain parenchyma, you can resect brain, but by the time tumor's gone into the brain parenchyma, the spread is it spreads in sort of a very unpredictable fashion. And even with brain resection, outcome is still poor. So only really I would do these sorts of cases if there's very minimal brain invasion, just focal brain invasion. Not if there's gross brain invasion, then really the evidence is that outcome is very poor.
How would you know that? On an MRI scan or
MR scan? Yeah, MR.
Okay.
Cavernous sinus involvement, significant cavernous sinus involvement, or clivus also means the tumor is not resectable. So when you think about the eye, the question you have to ask yourself is, can you resect tumor macroscopically and preserve a functioning eye? Most of these tumors always involve the medial orbital wall, the lamina, but you can still take the medial orbital wall and the periorbiter with preservation of the eye, because remember the periorbiter is a good barrier, it's a thick layer. Once the tumor is through the periorbiter into the orbital fat, in most cases then you would generally exenterate the orbit. Just small amounts of periorbital invasion actually mean you could still aim to preserve the eye. The one thing you have to bear in mind here is this: if you have preserved the globe and the eye whilst resecting periorbiter, some periorbital fat, maybe even some extraocular muscle, this patient was going to require adjuvant postoperative radiotherapy. When you irradiate the globe, actually, it's a very difficult situation because you can end up with a red, painful, discharging eye, which actually patients will really have major side effects from. And in many cases, you'd have been better off exenterating the eye to start with, or will end up exenterating the eye due to side effects. So this is just something really to consider with orbital preservation. So, although technically tumor may not invade the globe of the eye, once it's into orbital fat, then that's when you really start to think about needing to exenterate. If you've just taken the medial orbital wall, sorry, Haytham, go ahead.
Just a question, Mr. Mani. So when we are in MDT describing how far is the tumor into the
orbit,
orbit. So when you ask your radiologist, where do you think it stops from the orbital point of view? Is it only the bone of the lamina or the periosteum or the fat? So these are the layers you're considering?
Yes. So my main question is it through the periorbiter? Once if it's through the periorbiter and if it's into periorbital fat and extraocular muscle, that really means you should exenterate. If they say actually no, it's just through the wall and it's only just touching the periorbiter, I would think you can still aim for preservation of the eye then, as long as you've not got involvement more posteriorly along the orbital apex.
With considering radiotherapy post-operative, right? Because at that point you're not sure of the difference.
Yeah, exactly. I mean, you have to know the pathology at this point, but I'm saying, say it's a squamous cell carcinoma, you could still consider eye preservation.
Okay. Can I ask about the pathology? So would you prefer to preserve the orbit in an olfactory neuroblastoma, for example, or SCC or adeno? Does it differ? Or are
yes, it might. I mean, like I showed you at the beginning, the pathology actually does determine the aggressiveness of the tumor. So, if it's a low-grade tumor, like a very low-grade sarcoma or an olfactory neuroblastoma, then yes, I would think that you would more likelihood of trying to preserve the eye. Because we know these are less aggressive tumors. You remember we did a case of low-grade sarcoma last month, an MRI, and we preserved the globe, even though there was quite significant involvement, even involving orbital fat, but we preserved the globe in that case.
Okay.
Reconstruction, if you take the orbital floor, then you'll need to reconstruct that for support of the eye. You can use a number of things, split calvarium, titanium mesh, medpore, or if you're using a free flap, you can use part of the bone from that. The neck, obviously, if you've got N-positive disease, you need to do a neck dissection. If it's an N0 neck, there's very limited data as to what to do. You can extrapolate data from the maxillary sinus tumors, which show that for early stage tumors, you wouldn't generally dissect the neck, but in more advanced stage tumors, which by definition these are, you would tend to do a neck dissection if you're doing a free flap. So in the majority of cases, if you're doing a big resection with a free flap, you do a neck dissection as well. If it's an SCC, virtually every case will get radiotherapy. Like I said to you, you need to give a lot of consideration to these structures around there, particularly the eye. Proton beams are being used more. Actually, skull-base involvement is an indication for proton beam therapy. So this is being used more and more.
Do we know still the outcome of the proton therapy compared to the IMRT?
No, there's a trial just starting called PROTIS. Have you heard of it?
No.
PROTIS. This is exactly the question you're asking. It's IMRT versus proton beam radiotherapy in radiotherapy for paranasal sinus tumors with plus or minus skull base involvement. They haven't. It's only going to open next year, so they're going. This is the exact question you're asking.
Okay.
So say you only really give primary radiotherapy if you can't operate, and if you give chemo if you've got close margins as well. Neoadjuvant chemotherapy is used. Often if you've got borderline, these are all certain pathologies. So for example, in a SNUC, sinonasal undifferentiated carcinoma, you would usually give induction chemotherapy because you know they have a very good response. And you'd follow that up with surgery, then radiotherapy.
So is the rule here is to shrink the tumor to be resectable, or?
Yeah, in a SNUC, yeah, only in this particular case. In a squamous cell carcinoma, the response to induction chemotherapy is less, and the risk is you may miss your window of opportunity. If the tumor progresses, you may then become unresectable. So this is why, in general terms, if you can progress with primary surgery, this is the preference.
Yeah.
So we've gone through anterior skull base SCC. Difficult management problem, multidisciplinary approach needed. As I've said, histology type, extensive tumor, and adequacy of resection are the key. You want to see some cases, or you want to go through how are you doing for time?
Yeah, that's fine. Yeah, we're free. If we can go for cases, please. Yeah, as an example for the guys to learn from.
Okay, 74-year-old female, headaches, epistaxis. She had had previous surgery and radiotherapy some 30 years ago for a low-grade sarcoma. So this is the scan. See the tumor there, abutting the cribriform plate, involving the frontal sinus. And it's a low-grade sarcoma, biphenotypic sarcoma. But her eye, she'd gone blind from her previous radiotherapy already. And she'd had some pain in the eye, so her eye wasn't really useful. So we did this. We made a model preoperatively. This shows the extent of the tumor. This is quite good for reconstruction planning, making models like this. So this was a standard combined approach with a frontal craniectomy, where we, I don't know if you can make up these pictures, joined the two ends, made the bony cuts through the orbit, you can see, and we used an ALT free flap. These are the surgical steps, basically: bicoronal flaps, frontal craniectomy, left rhinotomy, orbital exent, dura opened, tied off the sagittal sinus, orbital intracranial cuts using the sonopet saw, which is like it's a bit like using the
ultrasound saw.
Yeah, exactly. It's very good. Okay, another case. 74-year-old male, left-sided nasal obstruction, epiphora, and epistaxis. So he had a left-sided nasal polyp. MR showed a sinonasal tumor with extension to cribriform plate, orbit, infratemporal fossa, lateral pterygoid plate, and it was an SCC. But it's a very extensive tumor, actually. So because they thought it was kind of not really resectable initially, we gave him radiotherapy, and then he had a good response to radiotherapy. So we then planned for surgery. Usually it's the other way around. So we did maxillectomy, orbital exenteration, infratemporal fossa clearance, net dissection, and a scapular free flap for him, which worked quite well.
So what? Yeah, why a scapula here? Is it because it covers two bony plates, which is the?
Yeah, correct. Because it was palate, maxilla, and we needed skin as well for the eye.
Okay.
This chap, I think you saw him, Haytham, didn't you, with me? He's the young guy who had a large mass, you can see very large mass in the anterior nasal cavity.
Yeah.
Now, again, you know, this would need a big resection. It's very significant involvement of the dura. And actually, it wasn't going, it was close, just really to the medial canthi, into the skin of the medial canthus, but not through the periorbiter, just pushing on the periorbiter.
Mm-hmm.
So because it was so big, we thought, well, maybe we should try some induction chemotherapy, see if we can shrink it. But like I said, actually, then it got bigger. This was with induction chemotherapy, it grew. So like, you know, I was saying to you before about this window of opportunity, this is how he first came. But then in actual fact, by the time we give him the induction, it grew through that. So then we're left with this case. So we then thought, well, there's no other option but to operate. We operated, did a total rhinectomy, took lids and medial canthus bilaterally with craniofacial, and we used an ALT for this reconstruct, which came quite well actually. You can see it actually pulled things together. His lid shape's a bit off, but overall, he was very pleased actually.
What is the safety margin of resection, Mr. Mani?
Oh, 1 centimeter you aim for.
Okay.
Yeah. These are other cases. Subtemporal approach. Good. That's it.
Brilliant. Thank you. So some questions from my side, please. How can we get a lower threshold suspicion of such cases from the initial presentation? Because whenever we present a case, sometimes it is quite a T3, T4 tumor. How can we pick these hidden cancers earlier? Is it with more scanning, or because if it is growing from the nasal cavity or the maxillary, You know, sometimes we can miss it as a polyp only. So
I agree. It's very difficult, really, because these cancers are asymptomatic for a long period of time or can mimic chronic rhinosinusitis, which is very common. So the main thing really is, one, if it's unilateral symptoms, this is kind of probably the biggest thing I would say. So unilateral symptoms or unilateral nasal polyp is definitely something that should be thought of more urgently. And also bleeding, because you don't normally get bleeding in simple inflammatory polyps. So if you've got blood-stained rhinorrhea or any kind of bleeding combined with unilateral symptoms, this would raise the alarm earlier.
An advice for the SHOs, would they offer a CT scan initially or an MRI scan in a unilateral nasal polyp?
Yeah, I mean, I think, it depends on your degree of suspicion. So if you're suspicious, I would get both straight off. If you think it's more likely to still be an inflammatory polyp, then probably a CT is still a first good choice for investigation, because you'll still get an idea with a CT of any bone erosion, which you won't get in inflammatory disease.
Okay. And for the biopsies, can we take biopsies in clinic, right, out of a unilateral nasal polyp?
Yeah, so I had that in one of the slides, didn't I? So the answer is, yes, you can. And often it's quicker to do this, but you may encounter bleeding and you will need to have some packing on standby. In an ideal world, if you can get a quick GA biopsy done promptly without affecting the pathway and taking a lot of additional time, this is preferable because you can assess the tumor better on the GA. You can do mapping biopsies as well, and it helps a little bit to plan your surgical resection, and you can control bleeding better on the GA. So in an ideal world, GA is good, but actually I accept that many occasions a local anesthetic biopsy is fine.
Okay, great. Any questions from the guys on the online?
Thank you so much.
No, thanks. We actually, I was in theatre in Trafford in the morning, and we excised a unilateral polyp which had unilateral nasal polyp which had metaplastic changes. You could see some metaplastic changes. So it was a very interesting case to see in the morning. And yep, I mean, we discussed the same case with my consultant in the morning, Mr. Kumar, who did teach us about flags and red flags and unilateral nasal polyps. So it was interesting.
Good, yeah, that's good.
Okay, Mr. Mani, if we can go through the paper which you advised of.
Yeah.
Can you see my screen?
Yeah.
So yeah, it's a nice paper actually. We're written in terms of how can we approach the T4B cases based on the American database, as this paper was published in November 2021 in the Head and Neck Surgery Otolaryngology journal, and the guys there took the data prospectively gathered from 2004 to 2016 in order to know what was the plan of management for the T4B sinonasal SCC tumors. And for the results, they had 805 patients, and the outcome was to measure the 2 years overall survival rate among the two arms, which were surgery plus adjuvant treatment or chemoradiation only. The materials and methods, as we said, it was a prospective cohort data collection for patients who has been treated earlier. So there hasn't been any randomization for the cases among two groups. And the patients who has been excluded who missed their follow-ups, or there hasn't been enough records on their electronic patients data, or the patients who has were considered to treat with radiotherapy, considering it for the primary site. So the two groups were the patients who had surgery and chemoradiotherapy, or the patients who has had chemoradiation alone. I think the results were based on the multivariate analysis and the Cox analysis in order to know through the Kaplan-Meier as well what is the survival rate for the patients. And there has been significant difference in the favor of the surgical arm more than the oncological treated arm, as the 2-year survival rate was 60.8% in the surgical arm compared to 46.7% for the chemoradiation cohort. So these patients, even among the results, there has been data about what is the surgical resection.
Haytham, just tell me those figures again, sorry.
Which figures?
The figures you just read out for the different cohorts.
So yeah, the results showed that the 2 years overall survival was 60.8% with 95% confidence interval for the surgical arm, compared to 46.7 for the chemoradiation cohort, which is a statistically significant difference in patients who has been treated with surgery.
Do we know what the pathology was?
They have been all SCCs.
All SCCs only.
Yeah, but the thing discussed on the limitations, I will get there now, was initially what was the intention of surgery in these patients? Has it been because of the MDT discussions about the resectability of the tumor, or was it intention to get surgery after giving induction chemotherapy? So this point wasn't a good start for the data, even if we have statistical significance. So that's why we know that surgery has been better. But what were the intentions pre-operative? Was it planned or not? That's the point for the data to be considered. And the other thing is the electronic records there. It records the overall survival, not the disease-specific survival, which means that some of these patients on the radiotherapy chemotherapy group might have died of any other disease, so we wouldn't know. But that was the thing described based on the overall survival. So right now, we know from this paper that the T4B patients who have been having SCC tumors involving the dura, involving the eye globe, involving the intracranial, who had surgery, which is not in the NCCN guidelines, as long as our resectability would stop in the T4A, T3. But even those patients in the US who has been operated on, who have been 805 patients, they had a 2-year survival rate up to 60%, which is quite considerable. So that is the advice of the panel, is to have more prospective analysis with a disease-specific survival on how can we approach these patients surgically, even if we know from the scans that it could be unresectable. The other thing is they didn't mention that there is any data related to the induction chemotherapy. So that's, I have flagged it in red. So here, so patients who may have received induction chemotherapy with intention of tumor downstaging and patient selection, those with a poor response will undergo surgery, and those with a good response will undergo chemoradiation. Overall, the rule of induction therapy may become increasingly important, but this hasn't been on the data analysis which they have had. So this is something to consider as well in these cases. So I think on our unit, Mr. Mani, I think we are getting to this point where we have been expecting much more better survival rates with even T4B cases. So if we followed the US data analysis, I think getting towards surgery from the start is a better prognostic value of these patients. Is that correct?
Yeah, I mean, that's my understanding as well, really. Sometimes many cases are borderline resectable, and, you have to take into account patient factors as well. So, if you have tumor with significant intracranial involvement, but is a young patient, that will sway your decision-making a little bit. And like I say, this paper does give some weight to the fact that if you can macroscopically resect a tumor, even if you can't achieve microscopic margins, there may still be some advantage to that surgically.
Yeah, sure. Good. Any questions, guys? Rana, I think you are on the chat. Are you still working on this patient leaflet? I think it's quite useful for our patients. We have seen last week 3 or 4 patients with Mr. Mani for skull base resection. So can you?
Sorry,
Hi, Rana.
I was on call, so I've just joined now. But yes, I'm still working on it. I'm liaising with the prosthetic team at North Manchester and Carly, one of the dentists, just to try and formulate a nice patient information leaflet. Still trying to see what the patients want as well, just to make sure that it's patient fitted and we're not like overriding them with medical terms essentially. But yes, it's a work in progress at the moment.
Mr. Mani, I think the good thing you are doing in clinic is showing the patient's previous cases, which has been done, because they feel some optimism in
Sure.
COVID.
Yeah.
So if you plan to add that, but on your records or mobile, this will be in addition to the leaflet. That will be good.
Yeah. You know, bear in mind this is a difficult group of patients because you're talking about significant functional and cosmetic sequelae from surgery. You know, it's this big life-changing surgery here. So there's a lot of things for patients to weigh up.
Okay. The last thing to ask from my side, how to follow up these patients over the 5 years? How often to offer them MRI scan, and how would we be suspecting a recurrence?
Yes, in general terms, after they've had their radiotherapy, they'll get a PET CT scan in 3 months' time. If the PET CT is clear, then we will monitor them in the clinic. You know, we'll generally see them initially every 2 months. We'd monitor them for 5 years in total. And in some cases, if they've had a free flap and it's difficult to assess the margins, then we might opt for some follow-up imaging with an MR scan in 6 months as a baseline. And then sometimes we'll get yearly MRs if necessary. But this is only in patients who are high risk. Otherwise, if we can monitor them clinically and they're asymptomatic, then they may not need any regular imaging.
Okay, brilliant. Great, thank you. Any questions, guys?
Very good, thank you. Thank you, Haytham.
Thank you, Mr. Mani. It's all recorded and it will be on our platform as well. Thank you so much for that.
Brilliant. Thank you very much. It's a pleasure.
Thank you. Have a nice day, guys.
Thank you. You too.
Thank you, Mr. Mani.
Thank you.
Thank you.
Cheers. Thanks.